Welcome to Neuro Frontiers, a series in which practical neurology partners with ReachMD to discuss topics at the forefront of clinical research and advancements that further clinicians' ability to diagnose and treat neurologic conditions. In this episode, Stavros Zanos, MD, PhD, Associate Professor at the Institute of Bioelectronic Medicine, Feinstein Institutes for Medical Research, uses neurostimulation as a means to study the nervous system and to treat diseases in which the nervous system is affected or implicated. In this episode, Dr. Zanos gives an overview of the current understanding of vagus nerve stimulation and shares important updates for future research and treatments beyond the nervous system.
Hello, I'm Joe Rusko, Editor-in-Chief of Practical Neurology. I'm very excited to speak with Dr. Stavros Zanos today. Dr. Zanos, please tell us a little bit about yourself and your research into VNS.
Sure. Thank you very much, Joe. Thank you for the invitation, a very kind invitation to speak about our work. So I started working in the field of vagus nerve stimulation, I would say about 10 years ago, while I was doing my postdoc at the University of Washington in Seattle. The focus there was more on the effects of vagus nerve stimulation on the brain of non-human primates. And around the time where we started publishing our work in that area, I moved to New York. I moved to Feinstein. And Feinstein, which is part of Northwell Health, the biggest health system in New York, has a tradition in the field of autonomic nervous system, vagus nerve studies, and specifically development of new vagus nerve stimulation treatments for inflammatory diseases. So all of this body of work has been going on for more than 20 years now. The president and CEO of Feinstein, Dr. Kevin Tracy, really started this field of we call bioelectronic medicine, which is the use of neuromodulation or neurostimulation of autonomic nerves to treat inflammatory diseases. So that's the context in which I joined Feinstein. In the beginning, I was also trying to find my little niche area within the field of bioelectronic medicine and neuromodulation. And we started looking into ways to improve on existing technologies of vagus nerve stimulation with a specific goal of improving them, meaning making them more selective, making more precise. One of the gaps that we identified was that when we place an electrode on the vagus nerve, that electrode delivers electrical stimuli, and there are action potentials going upward towards the brain, but also downwards toward the other organs, the peripheral organs, in a way that is not very controlled. So you have a single electrode, it's stimulating the entire nerve or parts of the nerve. We have no idea which parts. And that's important because the vagus nerve is not just a single cable connecting the brain to one organ. It's actually more than 100,000 cables connecting the brain with pretty much every visceral organ in the human body. And these connections are bidirectional. So some of them are motor, some of them are sensory. So you can imagine when you stimulate this bundle of cables, of axons, of fibers, you get a lot of different effects from a lot of different organs and the brain, of course. And it was just done in a way that, first of all, we had no idea which fibers VNS is activating. Second, we didn't have really a very principled way of stimulating the nerve in a more selective manner. For example, stimulating only the afferent fibers that go to the brain, or only some efferent fibers or motor fibers that go to one organ and not the other. So that's how the beginnings of the work in my lab started. We developed some methods to assess the activation and the level of engagement of different fibers to a variety of stimuli delivered to the vagus nerve. We measured brain responses. We measured responses of the heart, the lungs, and the gastrointestinal tract. And we discovered stimulus parameters and configurations of the stimulating electrodes that allow us to be a little more selective, a little more smart in our approach to vagus nerve stimulation. So that's one big part of the work we do in my lab. The other big part, maybe half and half, is how can we use neuromodulation to, first of all, understand the autonomic circuits that control inflammation. When you stimulate the nerve, you get responses from other nerves, you get responses from organs, and that defines, to some extent, how these organs speak to each other, how the nerve speaks to the organs and to the brain. So we use it as a tool to understand the organization, the functional organization of autonomic circuits. But more importantly, specifically, I think for this discussion we're having today, is the use of neurostimulation to treat diseases in which the autonomic nervous system is implicated. And more specifically, because of my clinical background, I'm trained cardiologist, we want to use these treatments based on neurostimulation to treat diseases of the cardiovascular system. You might think, how come? Like, what does the vagus nerve and the autonomic circuits have to do with cardiovascular diseases? And the answer to that is twofold. One, we know that the vessels in the heart receive very heavy autonomic innervation from the vagus and sympathetic nerves. So by modulating the activity of those nerves, we essentially regulate the activity of the heart at different levels, mechanical activity, electrical activity of the heart. But perhaps more importantly than that is the implication of inflammatory processes and immune dysfunction in cardiovascular disease. And not only, by the way, in cardiovascular disease, also in neurological disease, like epilepsy and depression, that makes this really interesting treatment, this treatment modality, because it turns out that the vagus nerve controls inflammation and the vagus nerve controls immunity. And again, that goes back to the early days of bioelectronic medicine in this building and elsewhere, where people studied this connection between the autonomic nervous system and the immunity. So just to put all this together, we like the idea of studying the autonomic nervous system because it allows us to understand how the nervous system and the immune system talk to each other. That's very important both for physiological homeostasis and for treatment of diseases. But then we also really like the idea of stimulating different nerves in different ways, autonomic nerves, to suppress inflammation, to partially reverse immune dysfunction, and apply those treatments in diseases, not necessarily of the brain, even though we are also looking into brain diseases and neurological diseases, but also diseases of other organs.
Okay, thank you for that. So as you mentioned, VNS has been used for some time now in the treatment of epilepsy as well as depression, and now you're investigating it for other applications, including in cardiovascular. Anything else? I've been reading about some non-invasive VNS used for even stress reduction. I'm not sure whether you have seen articles about that.
Yeah, there are several clinical trials and a lot of preclinical work in the field of non-invasive ways of stimulating this pretty much the same autonomic circuits, including the vagus nerve and other nerves, using electrodes that are either placed on the skin, like the auricular branch of the vagus nerve. I wouldn't call that vagus nerve stimulation. It's more like transcutaneous auricular stimulation, nerve stimulation. The assumption for that very common treatment modality is that it activates similar circuits as traditional vagus nerve stimulation does. And it, like you said, it's been applied to post-traumatic stress disorder. I mean, there are some very, I would say, compelling studies that show efficacy in diseases like depression and epilepsy. By the way, those are diseases that VNS has been FDA approved with implantable means. But of course, if we can also achieve similar effects with non-invasive methods, that would be great. People are looking into using both implantable and non-invasive vagus nerve stimulation in post-stroke rehabilitation, promoting cortical plasticity, regain of function after stroke. There are actually very compelling preclinical work looking into the use of vagus nerve stimulation in neurodegenerative diseases like Alzheimer's and Parkinson's disease. That's a very important area for clinical translation because it turns out that neuroinflammation or inflammation inside the brain is critical for the development and pathogenesis of neurological diseases, neurodegenerative diseases. So if VNS, either implantable VNS or non-invasive VNS, nerve stimulation is effective at controlling inflammation, that could have very significant implications for the treatment of these diseases that don't really have a cure right now. We have very few therapeutic options. So on the neurology side, there is a lot of interest. On the non-neurological diseases, again, the applications are mind-boggling. Not that they will all work. I don't want to give false hopes to people with these devastating diseases, but it's a very active area of investigation. There are preclinical and clinical studies looking at autonomic neuromodulation for obesity and diabetes, for hypertension, for heart failure and cardiac arrhythmias, for pulmonary hypertension, of which we have a particular interest in, diseases of the gastrointestinal tract, like inflammatory bowel disease, Crohn's colitis. I mentioned diabetes. These are very large diseases affecting millions and millions of people. I guess one of my messages is even if in one of these diseases, these autonomic neuromodulation treatments that are being tested works, that would be a huge deal.
Would VNS be a first-line treatment or as part of adjunctive treatment for some of these conditions?
I think the current thinking of most of the people working in the field that it would be an adjunct measure. These are multifactorial diseases. It's not just the autonomic nervous system that is, let's say, dysfunctional. There are many different metabolic and homeostatic pathways, endocrinological dysfunction, neurological dysfunction that presumably would not be corrected just by sticking an electrode on a nerve and fixing everything. But I think that to the extent that this treatment, when is successful at controlling immune dysfunction and inflammation to some extent, it really has wide implications for multiple pathways that are impacted in these diseases. And that's because in most of these diseases, if not all of them, this idea of chronic inflammation is always there. It's always implicated. It always makes the disease prognosis worse. We still don't understand exactly how and what is the role of chronic inflammation in driving worse outcomes in these people, but it's something that doctors from most of these specialties that treat these patients will recognize and appreciate.
Could you explain how to properly stimulate the vagus nerve here? So it sounds like there's more modulating treatments or interventions that you're mentioning. So it's less crude than it was in the past, and it's more modulated, I presume, right?
Exactly. That's the idea. If I knew the exact answer to this question, I would be rich. I would probably calling you from some Caribbean island from my yacht. That's the billion-dollar question: how to stimulate the vagus nerve optimally to suppress inflammation, to treat all of these diseases. The answer is we don't know yet. We're working on it, but there are some principles that we have uncovered. I would say one of the most important principles have to do with the anatomy of the nerve. So in humans, as well as in some animals, the vagus nerve, again, it's not a single cable. It's thousands and thousands of fibers, but they're not placed randomly inside the nerve. There is some, what we call spatial organization, some specific arrangement of these fibers inside the trunk of the nerve. So when you place an electrode around it, and if that electrode has multiple contacts, you can activate different parts of that trunk, different segments. Now, if we know that most of the fibers that control a certain function, like heart function, are localized in the north side of the trunk. And if we happen to have an electrode on the north side of the neural trunk, we can activate only those fibers by picking the right side of the nerve. The same for other organs, like the lungs, the gastrointestinal tract, or the spleen. I'm specifically mentioning the spleen because it's an organ that is directly implicated in the cross-communication between the autonomic nervous system and the immune system. If we could find the exact fibers and where exactly they are in the nerve that innervate the spleen or project eventually to the spleen, we could perhaps control inflammation without any of the other effects of vagus nerve stimulation. And if you ask neurologists, practicing neurologists that work with people with vagus nerve implants, with epilepsy, they will tell you that it takes a lot of trial and error to get the parameters and the intensity of stimulation right, so they reduce the side effects. And even at that point, they don't know if they are engaging the right fibers, the ones that suppress epileptic seizures at a level that is optimal. So there are side effects to vagus nerve stimulation that they don't sound very serious. Voice hoarseness, maybe some pain, weird sensations in the neck, muscle contractions, voice changes, but they actually are significant enough that the patients complain about them, and the physicians or the healthcare providers may be prevented from increasing the stimulation intensity to the level that they would like to have the full therapeutic effect by being more selective, by picking the right contact, the right frequency, the right polarity. All of these are parameters we are experimenting with. They can maybe localize the stimulus to the right part of the nerve that exerts the function that we want and doesn't have all of the side effects.
That's excellent. Are you creating a baseline map then of the vagus nerve to state that in general, this area in a certain number of individuals in your cohort is associated with sensory or afferent connections in or these organs?
That's exactly what we're doing. I love how you described it. We, for the past 2 years, we have been mapping at a microscopic level the vagus nerves of human cadavers with very detailed microscopy techniques, imaging techniques, anatomical dissections that allow us to specifically map how vagal fibers from the heart, the lung, the stomach, the spleen are organized spatially, arranged inside the vagus nerve. Also, what kind of fibers these are. There are sensory and motor fibers. There are fibers that detect mechanical stimuli. There are different fibers that detect the chemical stimuli. All of these are not randomly arranged inside the vagus nerve. We're trying to create a map that will allow us to build better devices and that will accommodate that anatomical organization. And that's a big goal that NIH decided that they wanted to reach several years ago and have funded 2 big anatomical efforts in human cadavers, our team and another team at the Case Western Reserve and Duke University, where we're exactly doing that. And we're trying to understand the microscopic anatomy of the human vagus nerve and how that can inform more selective, more improved devices.
Then ideally, someone who's performing VNS could model using your map about what the effect would be on their patient. So before they actually do the intervention through trial and error, you could model the probability of success digitally before doing the actual intervention.
Not at all. You're on target, literally. Yes, we actually are modeling how the nerve, through mathematical modeling and computational modeling, how the nerve fibers respond to different stimuli when the fibers in the vagus nerve are placed in anatomically, we call it anatomically realistic locations. So instead of modeling the vagus nerve as one single cable, we're modeling as a bunch of like 100,000 fibers, some of which are related to one organ or the other. They're placed in anatomically realistic locations inside the nerve because we learn about those locations from our anatomical studies. So now we have these virtual electrodes placed around the virtual nerve, but those are very accurate models. And we actually now have physiological data to validate those computational models with physiological data from animals. And they work pretty well. So we do these virtual experiments without any animal or human receiving an actual implant before we attempt the implant. And we know that, for example, we need 10 contacts or 20 contacts or 3 contacts to activate this particular function inside the vagus nerve when the anatomy looks like this. And one thing I would like to say, it's not published yet, but these publications will start coming out in the next few years, is the huge variability in the anatomical arrangement of fibers between individuals. We didn't expect to see that amount of variability. It's both a challenge and an opportunity for us, because if the goal is to make more selective treatments, we really need to be smart about how to design those treatments, how to administer the treatments. At the same time, it's a challenge because it's not easy, because not one treatment fits everybody's vagus nerve is a little different. So we need to find ways to accurately understand or infer the anatomical organization in patient A versus patient B versus patient C from functional tests. So that's another big chapter that we are very actively working on, and how to infer the anatomy of specific people, obviously without having access to the anatomical sample. We just have functional readings. We stimulate that side of the nerve, we get this effect. We stimulate a different part of the nerve, we get a different effect. So we're trying to understand that arrangement and functionally, so that we can optimize, can tailor the exact treatment to the specific individual. Those treatments most surely will be different between individuals.
I was just going to ask about that because I imagine that there would be an age-related effect on the vagus nerve that you would have to accommodate in addition to the anatomic, but then you have also cases when there's been damage to some part of that very long, very lengthy nerve there.
That's a beautiful segue. We really care about these sources of biological variability, we call them. So age is a big one, sex, male or female. We also care a lot about the effect of diseases. The vagus nerve samples every visceral organ in the chest and the abdomen, which means that we expect that any disease that affects those organs in a profound way might have effects on the anatomy and the function of the vagus nerve. We kind of know that because a lot of these people with these chronic disorders, neurological, non-neurological disorders, they have changes in their autonomic tone, heart rate variability, a response to autonomic stressors. So we know there's something different about the way their autonomic nervous system works. We think that this also reflects in the anatomy of the nerve. So that's why the functional tests are different. We think that this pipeline, anatomical pipeline we have developed, when applied to cadavers from people with specific diseases, might shed light on how the autonomic nervous system is both implicated in the pathogenesis of the disease, but also how it's affected by the chronic disease. All of that has to be taken into account in the design of treatments eventually. So it's a very large set of approaches that have to come together to create very effective treatments.
I imagine that this is somewhat controversial for, say, psychiatrists, for example, who have been looking at neurotransmitters rather than an underlying autonomic dysfunction, which is an implication of what you're saying.
I think that the system has very extensive projections to many brain systems. So just to remind people, the first stop of the vagus nerve, the sensory vagus, is in the brainstem, area called the nucleus of the solitary tract. And from there are projections to midbrain areas, to the cortex, to the thalamus, to the hypothalamus. There are very few brain areas that don't receive ascending action potentials from these vagally innervated structures in the brainstem. My strong guess is that any change in the function of the vagus nerve would be associated, maybe leading in some cases, or maybe associated with changes in neurotransmitters in many different parts of the brain. So I don't think it's one excludes the other. I think in many cases in psychiatric and neurological disease, these anatomical, physiological dysfunctions we find with the vagus nerve might also correlate, which in some cases might cause neurotransmitter dysfunction in different parts of the brain that are related to the psychiatric syndrome or the neurological syndrome.
What are the next steps?
We're also exploring, I guess I alluded to that in the beginning, alternative ways of modulating the activity of these autonomic circuits. And I would say the less invasive a device is, the easier it is to test it and eventually prescribe it to patients. So one of the stimulation modalities we're exploring in the lab, focused ultrasound. It's really a very high frequency mechanical stimulation that we and others have seen are able to activate neurons or to modulate the activity of neurons, depending on where you point it. If you point it to different brain areas, transcutaneous focused ultrasound, transcranial focused ultrasound, you get activation of different brain areas with big implications in neurological disease and treatment of neurological disease. We actually try to point it to abdominal autonomic circuits. So all of these connections between the vagus, the sympathetic nerves with intra-abdominal ganglia that project to organs and regulate their function. One of the organs is the spleen. Again, it's the organ in which the autonomic nervous system and the immune system come in close communication. We found that when we modulate the innervation of the spleen with focused ultrasound, we can actually impact the inflammatory state of animals, and a preliminary human trial, published randomized control trial in humans. So this is a valid technology, a feasible technology that allows the non-invasive, very spatially focused modulation of activity of autonomic circuits with effects, anti-inflammatory effects, that might be clinically significant. We don't have clinical evidence that modulating the activity of these circuits leads to clinically meaningful endpoints. We do have preclinical evidence for that in cardiovascular disease, in rheumatoid arthritis. Now we're at the point where we're starting to test this technology in very specific populations of patients, again, with cardiovascular disease and rheumatoid arthritis and other inflammatory conditions. If that turns out to be successful, then I think that's another big avenue for clinical research to test this idea of bioelectronic modulation of autonomic circuits for the treatment of diseases. This already happens in neurological disease in the brain and spinal cord. Because of the expertise of Feinstein and our lab in peripheral neuromodulation, we started focusing more on non-neurological diseases, but it's not limited to only those.
Thank you for explaining all that. It's exciting to see how the field is growing. Any last comments?
One last comment I wanted to make is that we researchers are generally very excited about our work. We're excited about the potential of our work to help patients worldwide to treat very difficult to treat diseases. It's easy to get excited about the potential role of these treatments, of these devices, of these methods in treating diseases, but the route to getting to real clinical translation is long, difficult, and expensive, and we should not make promises in the form that we found the panacea to all chronic disease or inflammatory diseases, to aging, to all of the neurodegeneration. I hear a lot of that on YouTube, on social media. We have to be really careful with those claims. They don't generally come from scientists, but they do mention the word vagus somewhere in there, autonomic. So these are bad words. People get very excited. People get false hopes about how powerful these methods are. We are taking one step at a time, very careful steps to really understand the principles behind whether these treatments work or not, how we can make them better, and how we can show efficacy and safety eventually in human populations, always through randomized controlled trials.
Excellent. I appreciate your time today. This has been very pleasurable.
It was a pleasure talking to you as well.
Thanks to Dr. Zanos for sharing his knowledge with our listeners in this episode of Neuro Frontiers. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the field of neurology.